Welcome, everyone. I am Tamara Hafner, Principal Technical Advisor on the USAID MTaPS program and the moderator for today's panel session. A few quick tips before we get started. The audience, as you can tell, is muted, and so we ask that you submit your questions and comments as we go along through the chat box. Please disregard the Q&A function at the bottom of your screen. We'll just be using the chat box to make things simpler for all of us. We're aiming for a very dynamic conversation today, so please feel free to submit your questions or comments or share any experiences you think are relevant as we proceed with the panel discussion. In terms of a bit of background, so as I mentioned, I am Tamara, Principal Technical Advisor on the MTaPS program. The goal of the program is to enable low and middle income countries to strengthen their pharmaceutical systems to ensure sustainable access to and appropriate use of essential medicines and related services. MTaPS is implemented by a consortium of partners, which is led by Management Sciences for Health. Any attempt to sustainably improve equitable access to quality pharmacy services must include strategic considerations of how to effectively leverage retail drug outlets, specifically pharmacies and drug shops. These outlets are often the first or only point of contact for health services, particularly in rural areas in some low and middle income countries. And so it's critical to give them some consideration. With that in mind, MTaPS is hosting this 5-part webinar series to explore the theme of advancing equitable access to quality pharmacy services through retail drug outlets. The ultimate aim of the series is to help highlight existing policies and strategies that can be used as elements in defining a pathway towards more equitable access. Today's webinar is the second in the series, and if you were unable to join us for the one that happened last week, the recording is available online, and information on the remaining webinars is also available online. And one of my colleagues will post the link in the chat for your reference. So as I mentioned, today's webinar is the second in our series, and we will highlight some successful interventions for reaching the most vulnerable. And with me, I have our esteemed and hopefully balanced panel to kind of walk us through this topic. We have Anne Foyer, who is Chief of Party for USAID ONSE Health Activity. And ONSE stands for Organized Network of Services for Everyone's Health Activity, a project being implemented by MSH in Malawi. And Anne just had a very successful closeout of that activity. So we'll hear a little bit about that, hopefully. We have Veronica Wirtz, professor in the Department of Global Health at Boston University School of Public Health. And BU is one of our esteemed partners on the MTaPS program. And you'll hear a little bit more from Veronica as we proceed. And as I go along, you'll see that the bios for each of the panelists is being posted in the chat so that you can read a little bit more about their background. We have Robert Tuala, Country Program Director for USAID MTaPS in DRC. And he will tell us a little bit about some of the work that's being done there around family planning and the expanding access to family planning services. We have Dr. Danielle Maura, who's a retail pharmacy owner in Nairobi, Kenya. And I think will lend an important voice to today's discussion because we often do not hear from the actual pharmacist on the ground. So welcome everyone, and we're looking forward to a very engaging discussion today. So, as I mentioned, we're sharing a brief bio in the chat for your reference for each of the panelists. So what can you expect over the next 85 minutes? We will start with a couple of basic foundational questions to get us all on the same page, and then we'll expand our discussion to really focus on highlighting some of the interventions that Robert and Anne have been leading in their respective programs. And then we'll also hear from Daniel as a retail pharmacist about his experience in Nairobi. And Veronica, with her expertise on pharmaceutical systems broadly and issues around equity in particular, will lend a very important analytical voice to this conversation and help us round out the discussion. So in all, we have about 45 minutes of panel discussion, 20 minutes of dedicated audience Q&A, and about 20 minutes of summation and closeout. And as I mentioned before, please treat this as a conversation. It really is meant to be. So as we go along, share relevant experiences. Please feel free to share any comments that you find relevant and ask your questions, and we'll try to accommodate them as we go along. Okay, and with that, we will get started. So our very first question is for Veronica. And Veronica, the question for you is, what do you see as some of the major gaps in equitable access to quality pharmacy services? What are some of the major pain points for the population with respect to accessing quality services? And how do these pain points differ between different segments of the population?
Thank you so much, Tamara, and welcome to everyone. It's so nice to see so many friends and colleagues connected from around the world who do so important work on this topic, which I believe is neglected. What do I mean by that? I think it's such an important topic that we talk actually very little about. And I'm so glad, Tamara and MTaPS, to bring this series about and say this is an important topic we should have a conversation about, and we should really pull in colleagues from around the globe because it affects all of us. So I would like to speak a little bit about why I think this topic is neglected. We have spent a lot of resources in mapping health facilities and have done large assessments on particularly public health service readiness around the globe. So what I'm referring here is, for instance, the World Health Organization Service Availability and Readiness Assessment, the so-called SARA tool. It has been created particularly for the purpose to assess the readiness of health services around the globe. Several countries have implemented this, have even done two assessments of the SARA with the SARA tool and have published their results. USAID has done similar efforts, very extensive efforts on something called Service Provision Assessment, SPA, and also extensively used by countries and published on the results. However, these do not include pharmacy services. So in other words, we know relatively well that public services are not up to the standards we want to have them ready. And what does this mean for patients? Patients would come to these services and find that the services are not in existence in the public sector, and then would turn to the private sector if they have the means to do so, and receive services there. However, there is a gap in our knowledge on knowing what these services, are these services available when patients need them, and also what the quality do they offer in terms of a routine assessment, similarly, equivalently, as we know them from the SARA and the SPA assessments. So I think it's a really, really important topic, and I'm glad we have that conversation. I would like to highlight equity gaps in 3 domains. One domain is the geographical access. A second domain I want to highlight is in terms of the affordability, and a third one in terms of quality of care. So the first one, the first equity gap in terms of geographical access, we did in 2019 a systematic review looking at geographic accessibility of pharmacy services. We had 20 papers, 20 publications that fulfilled our inclusion criteria. And in general, these publications showed that urban population have better access to pharmacies and shorter distances to travel. There were some exceptions, but overall populations living in rural areas seemed to be at disadvantages when it comes to accessing retail pharmacies. That's not a big surprise for us who work in the field, but it might come as a surprise for those not working in the field and not so embedded in the latest data. The second area I wanted to look at are the gaps in terms of affordability gaps related to wealth strata. We did a study in 2018 and looked at Kenya, where we found that affordability of medicines was lower for low-income strata. So we found that poorer patients tended to pay more for their medicines, and patients, for instance, we looked at asthma, in the poorest quintile paid more for their inhaler used to manage asthma. And in relation to wealth and median price paid for diabetes medicine, we found a U-shape. We found that wealthy patient paid a lot, but also poor patient paid a lot for their medication. So that was an interesting finding, and I think it's important to highlight that poor population also tend to pay more for the medicines. And the third area I want to highlight is regarding quality of care. There is some evidence that availability of medicines and related pharmacy services is lower in less wealthy neighborhoods. So there have been studies looking at the pharmacy services provided and the geographical areas related to wealth and the neighborhoods. And what they found these studies is that there is evidence from some high-income countries, for instance, the United States, where in poor neighborhoods, pharmacies typically have fewer opening hours, lower availability of medicines, and less pharmacies that offer additional services. What I mean by additional services is here, for instance, home medication delivery, vaccination, and blood pressure measurement. So I think in general, these are really important studies. We don't have many of them. We don't have a complete picture, but they point in the same direction, that we have at least 3 important gaps when it comes to equity and pharmacy services. Over back to you, Tamara.
Thank you for that very nice overview, Veronica. And I'm just curious from the audience, you know, in the different contexts in which you work, what does it look like in terms of these 3 domains that Veronica has highlighted, you know, in terms of affordability, geographic accessibility, and quality of care. Veronica, just a quick follow-up. One could argue that really thinking about equity, quality is assumed, it's implied, so it shouldn't even be in its own dimension. So it's the geographic accessibility to services, it has to be quality services to even qualify as a consideration for equity. Any quick comments or reactions on that?
Absolutely. And often, let's say, we separate that out. We say there needs to be, the pharmacy needs to be there. But what we don't talk about is not only the pharmacy needs to be there, but also this pharmacy needs to provide quality services, which actually speak to something, Tamara, that we saw in the literature, that there are several studies looking at the geographical availability of these pharmacy services, but many of the studies do not look at the quality of services that these pharmacies offer. So I absolutely take your point, and I think for future, thinking about this area and addressing it, particularly when governments now want to move towards universal health coverage and very much creatively think about how we merge private and public sector provisions, we need to think not only where pharmacies are located, but also what quality of service they offer and how do we monitor that quality over time. And we can speak more about this during the course of this webinar.
Indeed, thank you so much. And I'm just wondering quickly from your perspective, anything to add in thinking about these different domains of equity based on your experience working on family planning as a nurse midwife and director of the ONSE program? Let's unmute you. Sorry.
Yes, thank you, Tamara. First of all, let me thank the organizers for including ONSE in the program, especially including me as a person. I would like to respond to the question firstly by placing this question in the context of Malawi. To start with, Malawi provides free health care to nearly 100% of the population. So if you get sick, you can walk to any public health facility to get whatever care you need. But to provide that care, there are challenges for the country to provide the quality of care. And the issues that contribute to the less appropriate quality of care will include: 1, the health budget nationally is under-resourced or under-financed, because within the Africa region, there's a recommendation that each country should at least put 15% of its national budget for health care. But for Malawi, it is less than 10%. In terms of human resources for health, this includes trained pharmacists. We only have very, very few health workers to meet the health needs of the 18 million plus people in Malawi. WHO recommends 4.5 health workers per 100,000 population. In Malawi, we only have 0.5 health worker, or a vacancy rate of 47% for the health sector. Now, more relevant to our discussion today is the frequent stockouts of essential medicines. for both communicable and uncommunicable diseases. Now, looking at how has government or Malawi tried to leverage the private sector to address these challenges, my response would be the private sector in Malawi, its potential has not been well unleashed to support the challenges that I have just mentioned. The most significant involvement that I can share with the discussion today is the Memorandum of Understanding or a service level agreement that government has with the faith-based community, because the faith-based community in Malawi provides nearly more than 40% of health services to the nation. And these facilities are found in the hard-to-reach areas. So government, through this Memorandum of Understanding, the faith-based facility can provide care to the underprivileged people. Most of the focus is on mothers and children. So the district councils buy health services from the faith-based community so that these people can receive some type of service. So the service includes both consultation, diagnosis, and treatment, which means the medicines are also provided. Now, for the private for-profit facilities, there isn't much of involvement in determining the package of services or the cost of such a service, because Malawi has a liberalized economy. So if I open a clinic, it means that is my business, and I can decide what to charge, and I can decide how much I'll charge for the medicines. But what government has done is through the regulatory bodies, for example, the Malawi Medicines and Pharmacy Regulatory Board would regulate the medicines that are registered in this country, and they will look at the quality of the medicines that are found in the stores, but they also find who are the dispensers. They would like a dispenser to be somebody who has been trained, let's say, for example, a pharmacist. This is what a government would do. Also, if we look at those people that carry, let's say, medical schemes, the insurance companies decide what to charge. So basically, government does not have any hand in that. If that is done, government will be perceived as if they are interfering in the people's business. So the best that government does is make sure that the medicines that come to Malawi are registered, and the people that are dispensing are qualified, and that the medicines also passed through the quality assurance program that is done through the Pharmacy Regulatory Board. There are a few facilities that provide specialized care that have other service level agreement in addition to the one that goes on with the faith-based community, but these are really highly specialized facilities. Let's say if somebody would want to go, let's say for renal dialysis, or probably for a CAT scan, or very extensive orthopedic surgery and these medicines. So those are the few things that I can mention for the time being. The rest I will share as we go through the questions. Thank you, Tamara.
Thank you, Anne. Very, very, very interesting overview of the context in Malawi and some of the challenges that are being faced there. And we see actually some of the themes that we touched on in our previous webinar last week around, the need to regulate not only just the products, but also the staff, the pharmacy staff, to ensure that we have good quality services. So some really great points there. I see in the chat, Kusu pointed out that most retail pharmacies in poor neighborhoods are owned by independent retailers or pharmacists or entrepreneurs who source for medicines independently, often at expensive purchase price. So they are not competitive in their retail pricing, making the medicines costly to their patients and clients. I was actually hoping that Dr. Daniel could speak to this a little bit, but we seem to have lost him. I wonder if there's any quick comments or reactions from your side, perhaps Veronica, if, to the extent you can speak to this, this trend in terms of the sourcing of medicines and as a determinant of price. Yes.
Absolutely. So I really appreciate this comment that has been made, that obviously the price of the product is also determined by the source where it comes from. And we have seen that large chain pharmacies have the ability to source medicines often at lower prices. Whether they sell them also at lower price is not always a given. However, we have seen exactly the trend that was pointed out by my colleague in the chat, that independent pharmacies in some of these areas charge more or have to charge more to maintain sustainability. And as we go on in the seminar, I have also some comments about when we look at policies, what can be policies and what can policies look like to address inequities. But absolutely, and I think that should also be a focus when we assess equity and equity of pharmacy services, that we take this into consideration. In other words, pharmacies do not exist in isolation. They exist in a system, and the system depends on other chain links or other links in the system. And in this case, for instance, the suppliers of medicines and the prices that they charge, and what are the abilities of independent pharmacies to obtain medicines at certain prices.
Thank you. And I think Nadira's point around the limitation, the gaps related to country regulations for health services more or less touches on that point as well, and is highlighted in the comments that Anne shared earlier about the context in Malawi. I don't want to divert too much, but I see Birna is very interested, Veronica, in the explanation for the U-shape that you observed in the study looking at the affordability of medicines in Kenya. Can you touch on that just very briefly?
Very briefly, and very happy to. I will put the link of the study in the chat for everybody to look at. This is a very interesting question that Bruna is asking. One of the explanations that we had when we looked at the results is obviously that more wealthy patients are willing to pay more and to, so to speak, say, why not? This is convenience, this is close, I can afford to pay more. And then when we come to the lower part where we saw it again, increased expenditure, increased price that poorer patients pay, we saw the inability to move out of the places in which they're living. So our other colleague in the chat made the comment of in poorer neighborhoods, when you have independent pharmacies, that they charge higher prices. So when you then want to avoid being charged higher prices, you would need to move out of your neighborhood to access those prices, and the ability of the population is not there in terms of saying we are flexible, we can travel, we can afford to travel further, as let's say middle or more wealthy quintiles would be able to do so. So I think it's a very interesting phenomenon, and definitely I would see more studies in that area. Thank you.
Thank you, Veronica. So Anne, back to you briefly. You've already kind of touched and provided us a very, I think, good context of the situation in Malawi. And I'm wondering if you could just spend a couple of minutes telling us a little bit more about UNSAIN, the work that you've done around improving access. And I know one of the elements of that activity was changes at the drugstore. Could you tell us a little bit about that? What were some of the key outcomes with respect to service quality and access for the community? Over to you.
Thank you, Tamara. Indeed, as also we have been on the ground for the last 6 years, and we are just now in the process of closing out the project. So what basically we did as a project was to strengthen the systems set by government to ensure availability of medicines, as well as the quality of services. So the first thing that we did, because we're also interested to make sure that the private sector participates in one way or the other, we did an assessment to find the geographical locations of where these private facilities are. And indeed, we found quite a lot, but not surprisingly, because these drugstores or clinics are looking for money. So they are not very, very common in the rural areas. They had to reach areas where we are interested in. There are most of them in the urban and in the suburban areas. But through the assessment, what we discovered was that some of the clinics and the drugstores were unregistered. Remember earlier on I said what government does is to make sure that these facilities are registered, but we found unlicensed facilities. So as a good citizen in the country, we did report these clinics to government and to the regulatory authorities, and they closed them up and assisted them that can now make proper registration processes so that they can rightly perform their business. So basically, that's what I can say for the time being. But in terms of the other things that we did to make sure that there's quality of care, including access to at least quality medicines, we have built the capacity of district health management teams to carry out their oversight role to make sure that at least service level agreements are adhered to, because government is buying services. So we need to make sure that the faith-based communities, facilities are providing appropriate care for the essential diseases, but also the medicines that they are issuing out to the people of quality. We also built the capacity of the service providers in these faith-based facilities, that they are competent to manage the people properly and that they are adhering to the standard treatment protocols, because we know that in some clinics, the providers are looking for money, so they can overprescribe. And just when somebody just requires a Panadol and reassurance, we live with tanks and tanks of antibiotic and contribute to resistance. We have also built the capacity of the actual pharmacy personnel at the district level so that they can go to the primary health levels to now provide technical support to the pharmacy technicians that manage the primary health drugstore at the facility, mostly to look at how they manage the logistics and management information system, which generates information on the required medications, the usage, the ordering, and all that, to make sure that the government does not use the push system. Instead, it should be a pool. People should receive what they need instead of just heaping, like most development partners do. They just go and heap the drugs and then they get expired on the shelf. But we have also trained the health management committees, which is a combination of health workers and the community, so that these people are monitoring drug usage, because it's not uncommon to find that drugs are disappearing at the facility level into the communities or the markets. So once we have put up this oversight committee comprising of the community, they can take care of the medicine so that at least they end in the right hands. Another thing that we have done, because as a project, we were not procuring medicines, but we were managing the logistics management system to make sure that there's no overstocking. So what we are doing is to redistribute. If we find another facility that is overstocking, then we will distribute to those that are understocked. For the private clinics, what we did was basically training them on how to manage, for example, diarrhea in children, malaria in children, because people are likely to go to a pharmacy store and buy something, let's say if they think their child has malaria. So we trained the pharmacy owners that if somebody comes and they're asking for malaria, instead of you giving them the treatment, give them the proper advice that they are tested, so that when they are getting treatment, they are really being treated for malaria. So this is what we have done for at least the private sector, that they know the protocols and they know what it is that they can provide, so that they don't just give medicines willy-nilly, but also to advise the community through community sensitizations that when they are sick, the best thing to do is not to go to the drugstore and buy medicines, but to go to their nearest facility so that they are properly diagnosed and take the treatment better. But I just wanted to comment on what Veronica said. The medicine stores charge as high as they can, so they're not affordable to the community of poor people. Thank you.
Thank you, Anne. And I think what's really interesting about your response there is that you've really highlighted some of the key elements around good pharmacy practice, right? So proper dispensing, ensuring proper counseling, and proper use of antibiotics and other medicines, or appropriate use of antibiotics and other medicines. And I think also kind of really highlighting that, it's more of it takes a systems approach if we want to be able to extend access to quality services. So, the governance pieces around it as well, you've also highlighted in terms of the work that you're doing at the district level. So thank you very much for that. I see that Daniel, sorry, we've lost Daniel again. I wanted to get loop Daniel into the conversation here, because as a pharmacist, I think it'd been interesting to hear from him his experiences around working both in high income and low income neighborhood some of the issues around affordability from the pharmacy owner perspective. Oh, Daniel, you're back. I don't know if you heard my comment. I was wondering, both Veronica and Anne made the point around the fact that they find that the observation is that prices tend to be much higher in private outlets. And I was wondering and also the observation that both high income and low income patients pay a lot for medicines relative to those in the middle. So I was wondering if you could just comment a little bit on affordability to your clients, at least from your perspective as a pharmacy owner. How do you see it with pharmacies in both high income neighborhoods and low income neighborhoods? Over.
Thank you, Tamara, for having me and the rest of the panelists. The observation by Veronica concerning the prices being high in high-income areas, that especially in Nairobi, I would more relate it to the fact that most of the people in high-income areas would want to buy the so-called original brands. So they actually prefer buying the original brand because then they know the original brand is, in quotes, has a superior quality compared to the generic brands. Well, when it comes to the lower income areas, then people would, it becomes very expensive for them because the way they buy the medications, they normally don't buy in full doses, they will buy in small doses. And when they buy in small doses, to actually make the full dose, they end up spending more. But sorry, carry on.
No, sorry, go ahead. Go ahead, please.
Yeah, so what I was saying is that the sensitization about medication is really where now the private sector and the government, they need to team up so that people are able then now to understand the quality of medicines that is already registered by the regulatory bodies should be able to suffice wherever it is prescribed for. And in that way, then now the issue of price tends to become less. The other issue about people in high income areas is the fact that some of them also want to buy through the private insurance. And of course, the people who are providing private insurance give a full charge for the medication, and that tends to be more expensive for the patients, because then they are going to charge it to the insurance companies.
Okay. So there, I think one important point that you've raised, Danielle, around affordability and helping to perhaps close the affordability gap is sensitization around the quality, the assured quality of generics relative to branded medicines, and therefore promoting generic substitution as much as possible and having that being acceptable across different segments of the population. So and that, I think, at least at the high income level, but it seems so also at the low income level, where folks may also have a preference for branded medicines versus generic medicines. I want to, Robert, I haven't forgotten about you, and we kind of want to loop you into the conversation at this point. I was hoping you could tell us a little bit about some of the key pain points that the work that MTaPS is doing in DRC is addressing, and with respect to access and the role of the private sector. And I think you have some important examples, some really interesting examples to highlight. So over to you, Robert.
Okay, thanks so much, Tamara. Good morning, good afternoon, everybody. Actually, there are so many pain points that we can share with you today, but for the sake of time, I actually struggled to pick 2 or 3 of them that I can share with you. And for those also, MTaPS had a chance and opportunities to try to support and try to address in the context of the implementation of MTaPS project in DRC. So I think the first I try to pick here that is quite a big issue, I think, is the uncoordinated supply chain operation. You know, in DRC, we have a problem regarding the provision of medicine. I can say more than 70% of medicine, or I can say health commodity in general, that are being, you know, used in DRC are supported, you know, by donors. So they are donor funded. So they are funded by donor. Unfortunately, each and every donor you want to put in place his own supply chain mechanisms that are actually independent from each other, are operating in silo, making it difficult, you know, to coordinate a one supply chain in the country. So that's very serious, because we ended up having like some health zone being loaded with plenty of medicine, getting expired there, and just next to that health zone, we have another health zone that is running out of stock for the same medicine. So it was a kind of mess. So we needed to put in place a effective supply chain coordinating body that can try to oversee all the donor support when it comes to medicine provision. I think what MTaPS have been supporting, in each and every province, we have what we call medicine committee. So actually is supply chain coordinating body that you know, got the mandate to ensure that all the partners supporting the province where they are operating are adhering, you know, to the supply chain mechanism put in place by the government. So we try to enforce the alignment of all the donors, you know, in the government, with the ministry supply chain system, to ensure just that all the efforts regarding the provision of medicine, the management of medicine are coordinated by that governing body. So it was very interesting to see that it worked well. Most of the donors aligned in the system. So it helped, you know, eliminate a little bit this parallel kind of supply chain that operate in silo, and reducing irrationality and improving even availability of medicine and related supplies. The second thing that it was also important to improve the access is the community engagement. But after scrutinizing, we found that there was very insufficient, even a total lack of community engagement when it comes to medicine management. Community are more engaged in patient care related operation, but in management of medicine, they were totally absent. So what MTaPS did is helping also the ministry to ensure that community are engaged also in the management of medicine. So what happened, it's that we supported the ministry to organize some trainings, you know, capacity building on the basics of medicine management for the community members, to get them acquainted, you know, to the concept and language of pharmaceutical management, just the basics, because we will not go deeper in those concepts.
So,
As
Javier,
a result.
Sorry,
Yes,
Javier. So this community engagement, what was the expectation? Is it then that community members will be better able to judge the quality of services, or the way premises are being kept in terms of, what was the point with respect to improving quality of services?
Yes, so as I say, we just made sure that they are just dealing with basics in terms of medicine management, just checking if they are receiving the stock that are like answering the need of their health zone. Like when there are some stock out, they can, they can alert. Like now, as we are talking, those community members, they are playing a whistleblower role. We had some more cases where the community members alerted, the authority that in our health zone, we don't have malaria medicine. So what is happening, because malaria is one of killing, diseases here in DRC. So they are not going deeper in quality and so forth, but just checking if the stock.
Some element of accountability and transparency in the management of medicines. That seems to be that's for the public sector, correct?
Yeah, this is for the public sector. That's for the public sector. That's correct. Yeah.
So I think that's really interesting to highlight that, because then you see a role for communities to play in being strong advocates for themselves and being good stewards of the pharmaceutical system in terms of how it's managed in the public sector. I was wondering if you could speak specifically to some of the work that you've done around private sector engagement. So for example, you'd mentioned previously that in DRC, one of the issues was that the government essentially had, blinders on with respect to the role of the private sector in the provision of family planning. So I was wondering if you could speak a little bit to that and what MTaPS did to kind of help improve that situation. Over to you.
Yes, it was just even the following point. Yeah, so regarding the role of private sector in improving the access. Mm-hmm. So the pain point here was the non-inclusion of private sector data in the national statistic. So the first thing we did, we tried to identify programs where private sectors are deeply involved. Like there, we took the example of family planning in the provinces where we are supporting. So more than half of the population, when it comes to family planning, are covered by the private sector, including the retail pharmacy. So unfortunately, data from those private sector are not really included in the national statistic when it comes to family planning program. I think only 80% of private sector facility that were used, to collect data, only less than 15% of them, I wanted to say, report their data in the health information system of the country. So it is what we did. We wanted first to figure out the extent in which those private institutions contribute to family planning program, and then try to to identify the gap when it comes to the statistic that being reported now that exclude totally the data from private sector. recommend their inclusion, and then maybe adjust in near future, help adjust the statistic to include also the private sector, and then to get a clear picture, a real picture regarding the service actually received by the population. So I think for the private sector, our support started from there. So this is what we think to be the starting point if we really need to go ahead and try to ensure that the private sector are really helping in supporting the access, in improving the access to pharmaceutical services.
So really just addressing a very key information gap, right? So if we're going to be leveraging the private sector, we first need to kind of understand what is their current role, where are they located, what services are they providing, what clientele are they serving? So having some basic information as a starting point to take it to the next step. On your point, Robert, about the social accountability mechanism that MTaPS helped establish in DRC, I just want to alert our participants to some resources. One of them, Jane, has already shared with you in the chat. It's an approach to engaging civil society in social accountability to help improve access and appropriate use of MNCH products. And while it's specific to MNCH products, I'd just like to underline that it would be important and relevant for just about any category of medicines. So that's an important resource there for your reference if needed. I'm mindful of the time, but Robert, there's another quick thing I wanted to quickly highlight from DRC, because I think this is also important. And I'd like to also loop in Anne here to chime in, because I see parallels in terms of improving access to MNCH products in general. And that's around the activity, part of the activity that MTaPS led in helping the government define or expand an MNCH package for the population. And can you speak maybe just 2 minutes, please? Just tell us briefly about that, and if there are any resources, we'll also post them in the chat so people can follow up. So over to you, Robert, on the defining or modifying the MNCH benefits package.
Yes. So the point was here to reduce unnecessary referral, to referral hospital. The DRC is quite a big country. Unfortunately, we have a lack of basic infrastructure, in the country. So in rural area, there is a very big problem, like for maternal and neonatal and child health program, MNCH, where we need to have, some key items like amoxicillin, chlorhexidine, and other to be very available, to ensure that children and even the mother are taking their treatment at the place they are staying. Unfortunately, you found that in many health area, you have a referral hospital only maybe at 10 kilometers, and for just the lack of a product like paracetamol, amoxicillin, you can get people being referred to go to a referral hospital that are more than 10 kilometers away, and that's a very huge burden for those populations. So what we did is try to bring the service closer to those populations. That's why we define it. We help actually the ministry to define a community package. It was not only for MNCH, but even for family planning also. So we had a two reduced package that are meant to be used at community level, just to ensure that a member of the community can get their medication without being referred to the referral hospital that are very far from the place they are staying. So this made a very huge difference also to alleviate, their pain. The problem is only the financial resources for those populations that are poor. So they cannot afford only for paracetamol being referred to more than 10 kilometers to get just the paracetamol. So really the definition and availing a package that will be served, delivered close to their setting, it was very, very important. It is what MTaPS supported, and I think it's giving already a big difference in terms of alleviating, their pain in terms of unnecessary referral, and also trying to help them to save their money instead of using them for the transport going far away from where they are staying. Over to you.
Thank you, Robert. And so I think that nicely illustrates one of the ways in which at least MTaPS is able to kind of address one of these equity gaps, one of the domains that Veronica pointed out earlier around geographic accessibility, bringing the services closer to the community, and in that way also introducing some efficiencies, avoiding unnecessary referrals and additional transport and expense on the part of the patient to access the services that they need. Thanks for that, Robert. So moving along, Anne, I just wanted to quickly, I know that ONSE just wrapped up, and I was wondering, given the discussion and overview that Robert just shared, from your perspective with ONSE, can you just talk a little bit about some of the impact that you've had, whether in terms of child health or maternal and newborn health, in terms of the access to services and what that looks like? Just 2 minutes, please. Over to you, Anne. Oh, and actually posted something in the chat. I don't know if you want to verbalize that.
Thank you, Tamara. Yeah, I was just going to say I've put something in the chat, but the issue of access to care is indeed a challenge. Not all populations live nearer to their facilities. So as ONSE, one of the things we invested in is to support the district health management teams to conduct outreach clinics monthly. So in the 6-year period, we have actually supported more than 10,000 outreach clinics to various communities in the country. And through these 10,000 outreach clinics, nearly more than 2.4 million people have accessed a package of services that included family planning, immunization, HIV testing and counseling, growth monitoring, just to mention a few. So we noticed that we cannot leave these communities unserved. So through these outreach clinics, the people are assured of services being available, but also the medicines that are used in these clinics are the ones that have already been registered by the pharmacy board, but they have also passed through the quality control. So we are assured that when the mobile clinics are available, the people do not have to go to their grocery store and buy probably a fake paracetamol or fake malaria drugs. So this is what ONSE has managed to do. You can imagine that the areas where we have high fertility rate, family planning services were available at community level, even to the youth themselves. We also had the village clinics where community health workers were treating under 5 children with, let's say, that have either malaria or diarrhea, and we're using a qualified drugs that have passed the standard. Because the challenge that we have is there are some not people out there in the community that will sell anything in the name of a drug. I mean, the community member would not know that what I'm being given is not an aspirin or is not something. So through these clinics, we have managed to make sure that at least there is some equitable distribution of health services to the rural poor. Thank you.
Thank you. And again, we see, the theme around geographic accessibility being so important here, and bringing services to the community, whether through outreach clinics or other mechanisms, has been helpful in improving access. And there's a really nice graphic and on the UNSAY, the outcome of the UNSAY program. I'm wondering if it's available publicly. That's something that we can share with our participants. Is there a link we could share with our participants on that? It just really, I think, summarizes some of the key achievements around improving access to medicines and other services and health services in general for different groups. And is that graphic publicly available?
Sorry, can you come back again with a question?
I know there's a really great infographic that was produced by the UNSAY program as a PDF, and I know it's internally available to MSH, but I'm wondering if it's publicly available and we could share it with the participants so they can get an overview of some of the impact UNSAY has had in improving access to medicines and health services in general. Is there a link?
Sure, yes, I can share with you the infographics, but like I said earlier on, the issue on dealing with the private pharmacies was really very little other than the assessment and teaching the private clinics to manage malaria properly and how to dispense family planning issues, something like that. But I will share the infographics with you so that you can have a general overview of what the UNSAY has done. But the major thing that we have done is that at least we alerted government that there are people out there that are running unqualified clinics. And because of that, government has gone in. So we are now happy that at least people that are managing these clinics are managing them properly, except that they haven't managed to look at the fee because they are business people. So that is something that government has now to start negotiating. Thank you.
Thank you. Thank you, Anne. Danielle, I just want to quickly, if in 3 minutes or so, if you can just give us, you've spoken a little bit about some of the affordability issues between high income and low income areas, but I'm wondering if you could just spend a little time telling us a bit more about your experience as a retail pharmacy owner. I know that you have pharmacies in both across all three segments, middle income, high income, and low income neighborhoods. And what has been some of the key enablers for ensuring access? And here I want to focus specifically on the poorer segments of the population. So in the urban, rural areas that you're working in Nairobi. And what has been some of the challenges? And in answering that question, I want to quickly alert you to a comment or a question from Kusu. Do we have any example of what incentives have been provided to private pharmacists to maintain low pricing and any required reporting to the public sector? So in giving us a brief overview of your experience, we can also touch on any incentives that you've observed from your side as a pharmacy owner that's been provided by the government to help with reporting and also help with keeping prices affordable. Over to you, Daniel.
Thank you, Tamara, for that question. What I've observed over my couple of years in community pharmacy is the huge difference between the high income areas, the middle income areas, and the low income areas is that whereas in the high income areas, we have a lot of patients who will come for chronic illness, refills, diabetes, hypertension, the non-communicable illnesses. And majority of them also have access to very good healthcare. So they are well-educated people. They have access to technology. So if they need to talk to their doctor, they can even do a video call to the doctor. Ease of diagnosis for their illnesses and access of their medications. Most of them have pharmacists that they trust and they liaise with, and majority of these outlets in the high, like the ones we have in high income areas, we have probably 3 to 4 pharmacy people who are attending to the patients. When it comes to the middle income areas, you actually find that the number of people providing the service decreases, and it even decreases further in the lower income areas, because number one, you need to pay for the people, need to pay for the space, need to pay for a number of things. So basically what happens is that in these areas which are, number one, very highly populated, they tend to have a lot of communicable illnesses, and majority of the people come to the pharmacy as a first place of healthcare requests. So when they'll have anything, so they'll just come, and because they are also in situations where if they went to the government facilities that are around, the government facilities lack majority, or they don't have a lot of, they're also understaffed and understocked in medications. So they want to come to the pharmacies. And when they come to the pharmacies, they want you to come up with a diagnosis. So number one, it's probably not the correct diagnosis. We have a challenge. We can't call for conversations in these areas, and so these are the type of challenges that we grapple with in the lower income areas. And just to step in and say that the government tries to have the universal healthcare, but unfortunately, it doesn't trickle down to the private people offering the services. So there isn't much we can say that the government is giving support to the people who are doing all this, in as much as the regulators want to come and try to clamp down on the quack pharmacists. That's all I can say that I've seen a lot of the hand of the government. But in terms of giving the need to the community that are in need, who are in need of these services, we actually need more. If the government could increase the training of healthcare workers, so that we have more people who are able to offer services. And also, secondly, there is this mentality which we have in our country. Let me talk about our country, where many people think that the more expensive a medicine is, the more superior and the more effective the medication is. So you find that people spend so much money trying to buy or procure that medicine that they consider to be superior, which is not necessarily the case, because the pharmacist is able to identify, like myself as a pharmacist, I'm able to identify this is a good product that can be stocked in this particular area, and it will be affordable by the community. And if the community was to go by what I have made a judgment for them, then they should be able to get some substantial benefit. I hope that answers the question. And the challenges, just like had been highlighted earlier, you find that in access to healthcare is a big problem. And why it is a big problem is the fact that there are many outlets, but they don't have all the products that are necessary to take care of the problems that are in a particular region. Another big concern that I've seen is there is poor adherence to the medicines that have been prescribed for the patients. And the poor adherence comes because of Number one, inability to understand why you need to complete a particular dosage. If it is a dosage for antibiotics, you need to complete a particular dosage. You find many people, because they're probably daily wage earners, they want to say, give me half a dose, I'll probably come for the other dose much later. And that's a big problem, because if you don't, then if you improve slightly and you think you're cured, so you discontinue the treatment, and there is a risk of having other consequences of not adhering to your treatment. And that's a very, very big challenge, where people, and they because of the affordability, so they want to buy the dosages in bits.
So,
and sorry.
Yeah, so Daniel, I think this is, you make a lot of rich points here. One, we see where there is, of course, healthcare seeking behavior differs between high income and low income groups, but like focusing specifically in low income groups here, we see where the needs are slightly different. There's a higher emphasis on communicable diseases. So more likely need for more antimicrobials. And then one of the issues we're highlighting here is that among patients, I think as one way of coping with affordability, then the private outlets are more convenient because they can get partial doses. That's one thing. But then, you know, they feel better. They don't come back to complete their dose, whether because they feel better or because they can't afford it. And then you have issues around potential increase in antimicrobial resistance. So that's one thing. But then the other thing I think you've really highlighted well is their pieces here in terms of thinking about access, right? It's multi equity and quality of pharmacy services. It's really multidimensional, and I think this discussion brings it up quite well, because there's a part of the pharmacist or the pharmacy owner, the retailer, right? But on the part of the patient, recognizing the equivalence of a generic versus branded version of medicine, and the fact that if a medicine with adequate regulation, right, from our national regulatory authority, that, you know, price is not an indication of quality. So, you know, it doesn't mean that if the medicine is more expensive, it's going to be more effective or not. So even some basic patient education, I think, is needed to benefit patients themselves and the system more broadly. I want to quickly pull in Veronica here, just you know, as a reflection on the points made by both Daniel and Anne. If you have any quick thoughts that you'd like to share with us, Veronica.
Yes, I think for me it's really important to point out a set of policies that we could think of, in other words, strategies that we could think of addressing inequities in terms of access to pharmacy services. And three kind of broad areas come to mind. The first one that comes to mind is the franchising. In other words, to set a minimum set of standards that we expect a group of pharmacies to offer. Anne spoke a bit about it. She said, we demand from these clinics, wherever they are, the outreach clinics, to provide a minimum quality of services. And similarly, this kind of idea of franchising in terms of retail pharmacies has been taken to scale. Obviously, many are connected here. Many of my colleagues and friends very well know the Tanzania example with the accredited drug dispensing outlets. This is one example, but the beauty of this example is it's so well documented. We know that has been, I think 2015, was at 9,000 accredited of these outlets distributed throughout the country. So we had a relatively high density, if you want, 5,000 people per adult. There have been good documentation of, indeed, it kind of increased the quality standards of services delivered. There were challenges, and these have been documented with, for instance, enforcing such standards, maintaining such standards, all well and good. But I think the idea of franchising, the idea of saying we set the minimum standards of quality of care and enable them to obtain their medicines from certain distributors, etc. So it was kind of a system thinking approach in that sense. Embed these pharmacies also in ways in which they can obtain quality assured medicines, and then providing them with a specific training to provide such services, not only products, but plus quality services. The second set of policies and strategies I would like to think about is this, let's say, Farmacia Popular model, or sometimes also in India, the model of certain outlets offering low-cost generic medicines. And this goes a little bit to the comment that I just saw Birna made in the chat of saying, when we set prices, can we expect these outlets to offer medicines at a certain price? And I think it would be interesting to look at models like Farmacia Popular in Brazil, or maybe in India, they are usually medicines that are outlets that provide quality assured generic medicines at a certain price. And both models have been documented. I think the Farmacia Popular probably more than the Indian up to now. But we have evidence there that, for instance, in Brazil, it increased the offer of access to medicines, particularly for non-communicable diseases, which I find very timely given the debate. And I heard several of our speakers pointing out that there is an unmet need for non-communicable disease medicines. And also the scheme Farmacia Popular has not eliminated inequities, but at least there's evidence saying that it has potentially improved access throughout the country. And then the third area of set of policies and strategies that I think is important to highlight here is the incentives for pharmacies to remain functional and opening in rural areas. And there, I think my knowledge is a little bit more, a little bit better from the European region, but I think it can be used also to identify examples from other countries, and those, my colleagues from other areas might be able, other geographical areas might be able to contribute here. So for instance, we have seen this with Estonia, where pharmacies, a very small country, Eastern Europe, has provided, for instance, community pharmacies or branches with kind of a specific incentive if they were going into these rural areas, a specific once-off allowance. Or for instance, Spain, providing smaller pharmacies with a monthly allowance. Or for instance, Scotland, Ireland, Northern Ireland, Wales, similar system where there is a kind of like a small minimum distance to pharmacies, and if this is the case, the government would support such pharmacies to stay open. I think all these three strategies or packages, well, I would say policies around these areas, I think are promising, and we can learn from these. So I would encourage us, when we now go forward thinking of this in terms of what are policies and strategies we could successfully roll out in other countries. Thank you.
Thank you, Veronica. And that, I think, also helps to address one of the questions raised by Kusu around whether or not there are any incentives for engaging the private sector to keep prices affordable, and also in terms of reporting. I think the Pharmacy Popular model that you highlighted is a very good example of this. And I've posted some resources in the chat for folks if they would like to learn more about that. Just a few minutes to quickly address any other questions. Also, Veronica touched on the ADO accreditation model, and Management Sciences for Health has a big history in this area of work. And my colleague Jane has posted some resources as well if you're interested in looking at that. And as Veronica has highlighted, this is well documented. We know what's required for accreditation. We know some of the challenges and how to, so there's a lot there already, and I no need to reinvent the wheel on that. The other thing I wanted to quickly highlight is that, both in the chat, Kusu has talked about the role of the faith-based organizations, and has also mentioned it in the context of Malawi. And regrettably, we have one of our partners, the Ecumenical Pharmaceutical Network. They do a lot of work in this area. They are a network of Christian health associations, and they focus specifically on improving access to medicines. And they often work in some of these areas that we're particularly focusing on here around, the poorer segments of the population. Unfortunately, they weren't able to make it today, but if you're really interested in hearing a little bit about EPN and just the role that faith-based organizations play in enhancing equitable access to quality pharmacy services, I just a quick plug here, our session on, I think, July 6th we'll have the director of EPN here, and we'll hear a little bit from him. And there's information about that in the webinar link that you used to sign up for this session. So please join in there. But again, just want to highlight the faith-based organization is a key voice in this, because they, especially in sub-Saharan Africa, they play a huge role in the provision of health services in rural and poorer areas. And so it's important to hear their voice as well on this, and we'll get a chance to do so. Just quickly looking through the questions, I think Huso also pointed out that an incentive in Kenya for faith-based organization health facilities has been the provision of human resources for health, so providing nurses and clinicians by the government. So there you have a partnership between the government and the faith-based organizations leveraging resources. And in most LMICs, there's a broad confusion myth around generics and counterfeits, hence the need for education and advocacy. And we can't highlight this enough. As I mentioned before, and I think hopefully one of the takeaways from this, and I think Veronica just highlighted it quite well, we really need a systems approach here. And so thinking about not just the role of the retailer, but there's also a role to be played in terms of the patients, the population themselves, in terms of being good, strong advocates, and also being educated around the quality of medicines and, pricing, the role of generics and the, promotion of generic substitution to help keep some of the prices affordable. And then of course, none of this matters if we don't have strong regulatory systems. And we had a webinar on last week, and the recording is available online. My colleague could just post that in the chat, where we really touch on some of the elements around good pharmacy practice. And I think it's highlighted really well there, the role and importance of a strong medicines regulatory system, both for the products, but also regulation around the pharmacists themselves and the standards of practice, and around the premises and the quality of services that are provided. So I'm very mindful of the time. I just want to quickly now touch on, I think we've had a very rich discussion. We've heard bits from Kenya, we've heard from Malawi and some of the programs involved. We've heard about the situation in DRC and some of the work that MTaPS is doing there. And Veronica, I think, has done a really excellent job of kind of really making the connections between some of the experiences that we've heard, but also what our current state of knowledge around equitable access. And she's highlighted quite well some of the key domains around equity and some of the policy options that exist. So I just want to quickly turn back to our panelists now, and within just a couple of minutes each, could you, given some of the successes and challenges that we've discussed briefly in your view, can you highlight one critical element or factor that national governments need to prioritize to better engage the private sector in expanding access? And Daniel, I'll start with you. As a pharmacist, is there one thing that you think the government can do to better engage you in terms of providing services to the urban rural poor, the area where you're working in Nairobi? Over to you, Daniel.
Thank you so much. I think the government needs to come out very, very strongly in promotion of locally manufactured generic medications, and have education around it, where community health workers are going to be used to explain the role of generic medications to the rest of the population. That's number one. Number two, I guess we also need, like in the lower income parts of the community, the government needs to come out very strongly and assist or with things like the water supply, provision of mosquito nets, where now they'll have to work with NGOs and other organizations that are involved in public health, because eventually we need to do more preventative medicine as opposed to curative medications. So the government needs to come out very, very strongly by having more people on the ground to educate the community, providing community education, and very, very strongly also coming up with village or area councils where from time to time, I guess it used to happen a while back when we were kids, where we would have people come and explain to us, educate to us, talk to us about the importance of hygiene, importance of draining stagnant water around our households. So more to do with preventative training, where the government will strongly come and work with the community. But then when it comes to the equitable access of medicines by the people who can't afford, the emphasis really is going to be where the government, working with the regulator, is going to register brands that are proven to be effective and to be of a high quality. And they are also going to seal loopholes where people just import medicines. On that point, what I'm actually talking about is counterfeit medicine, so that you also reduce the amount of counterfeit medicine. And that's only the government that is able to play that big role of stopping counterfeit medicine, which is another big challenge, because there are many people who want to buy original medicines and they enlist poor setup areas. They actually will go and buy something that looks like an original product, but it is priced at less. It's well priced, but essentially it might be a counterfeit medication. So that's another big challenge where we need the government to come and intervene.
So Daniel, just to highlight for our audience here, so strong regulation of the products, but also from your perspective, noting that for the clientele that you're observing in the rural areas, you work in urban rural areas, the big demand is to treat communicable illnesses, and so there needs to be a part on education yes. around prevention of these diseases. So hygiene and other areas around, so some other social interventions around that. And then so I just want to highlight those two quick things. One thing from the side of the government, but there's also something from the side of the community that they can also do. Over to you quickly, Anne. In a word or in a sentence or two, can you just quickly tell us from your perspective, is there any one thing you see in the Malawian context that the government can do better to engage the private sector in advancing equitable access?
Yeah, thank you, Tamara. I think what I would want to conclude my contribution to this discussion is one, that we need to create trust between the private sector and government, because usually there's a distrust. The private sector would look government as somebody who's interfering. So there should be a deliberate effort to create a forum, both at national and the district level, for the private sector and the government sector to realize that they are all chasing one goal, to save the people's lives. So if that understanding is there, I'm sure the private sector, when they come in with their commodities, they will realize that they are there to save lives and not just to make money for themselves. Secondly, I agree that we need to do a lot of prevention work, but one day someone will get sick, they will need the interaction with a healthy provider. So I would want to propose that probably in the places like Malawi, where there's very tight fiscal space to employ more health workers, but we have unemployed health workers. So if this can be mobilized so that they're encouraged to build the clinics in the hard to reach areas, because the clinics that we see now are in the urban area. There's nothing in the rural area. So I think if we can manage to mobilize these unemployed health workers and encourage them to provide that type of service at the rural level, and the government can buy services from them on behalf of the people, I think if we do that, we'll be able to solve most of the problems that we see. Thank you.
Thank you, Anne. And Robert from DRC, and given the work that you've been leading under MTaPS and more generally knowledge of the context, is there any one thing that you can point to that the government can do to better leverage the private sector for to enhance access, equitable access?
Sure. Thanks so much, Tamara. I think first of most all, I think government need to enforce private sector adherence to established policy. The study we just conducted, what I shared with you regarding the family planning item consumption, revealed that around 80% of private sector institutions that are delivering the services are not officially registered. So that means that they are operating illegally in the country. They are quite a majority when it comes to to covering the population in many kind of program like family planning and so forth. But they are operating illegally. So you will agree with me that that may not really help to ensure that the service they are delivering are up to standard, and they guarantee the quality of the service and the safe, the safety of the treatment they are rendering to the population. That's
so enforcement. Sorry, we're at times. We're at times, so I'm gonna stop you, Robert. So enforcement of regulation is very important. But then that raises another key important point, I think, around the assumption of the existing regulation. So is existing legislative and regulatory framework sufficient to enable to monitor and to regulate the services, the quality of the services. So enforcement again, and of course the necessary laws to ensure that. We're at time, so Veronica, I'm just going to turn it over to you very briefly. Can you just give us a quick summation and global outlook given the conversation that we've had today?
Yeah, we had a wonderful conversation, and thanks everyone for joining. So very quickly, in addition to the 3 policy areas that I had highlighted, offering low cost but quality assured generics, incentive for pharmacies to keep open, remain open in rural areas, or being created in rural areas, and franchising, I would like to add that I think the emphasis on really acknowledging the importance of pharmacies as part of a functioning health system. And therefore it needs investment, it needs the government as being very proactive in that area, creating trust. I like a lot the theme that Anne mentioned. And this would also require the government to measure not only access, not only quality, but take into consideration the equity dimension. And I think many of us spoke about that, the need for better information and data to make decisions and base our decision on. So that would require the government to routinely measure the equity dimension of access to quality services and quality products. Thank you, Tamara.
Thank you very much, Veronica. To our panelists, Anne, Robert, Danielle, thank you so much for your time. Thanks for all the wonderful insights you shared with us. To the audience, thank you so much for joining us today. We've shared with you some resources and thanks for the questions and the comments in the chat. And we really thank you for helping to make this a very engaging and interesting conversation. Thanks, everyone. The webinar series continues. The next iteration is next Wednesday, and information on the series is posted in the chat. And you can also find information at the link where you signed up for this webinar. Thanks again, everyone, and enjoy the rest of your day and evening. Stay well. Take good care. Bye.
Thank you. Bye-bye.
Bye.